Anyone? All right. So what I was trying to say is that like how I got my All India rank was in just 6 months. In 6 months, what I did was I did an integrated way using multiple platform notes and getting it done. The main thing what you guys need to know that we have 3 weeks right now. In this 3 weeks, we are going to make sure that all the must-know topics has to be revised regularly. Along with this, if you're able to do 5 years of NEET PG, 5 years of FMG, and 3 years of I9, you don't have to do anything else. Make sure you get these things done, and regular revisions are very important. The main idea for this sessions are that whatever we discuss right now, we will not have any other doubts later on. We'll be speaking in English so that we'll have everyone can understand properly, and we'll have basic interactions as well. We'll try to make this as much as interactive session as as we can. So I request most of you kindly please turn on your video also so that you guys can feel that you're actually in a classroom. Now, the second thing what I want to tell you is that why 399? Why the price? The price is just for you so that you guys understand that you have paid something. Otherwise, if it was free, people will not be too serious about it. So make sure you be full religious to this. These 3 days, and especially 6 to 9, we usually are very lethargic. Either it's dinner time or either we're very exhausted from our morning hour studies. So that is why this time I have chosen. So we are going to start with medicine. We're going to have a mix of pharmacology, surgery, and a lot. Did someone say something? I didn't hear properly. Is everything okay? Is everything okay? Okay, cool. So one more thing is, now whenever I'm going to ask questions, I'm going to ask random questions, all right? So then when I'm going to ask random questions, I'm going to ask by picking out some people, and I'll expect you guys to answer as well. Because this thing, the entire session and all, it is based on confidence. I'll like to share you something about myself as well. I had a couple of people, who are very sharp in studies. But during the FMG exam, when there were so many tricky questions, just because of their anxiety, their scare, they were not able to pass the exam. So take this session as an overall build, not only as studies, not only for confidence, but it's a combination of all. Lastly, if there is someone who hasn't studied so far for the upcoming FMG exam, if they're worried that can I clear my FMG exam, yes, you can. My own sister, she studied for 1 month. Okay, we studied together. I made her teach all the important topics and all, and she was able to pass the FMG exam within 1 month. Obviously, now the score would not be that brilliant, 220, 230 or something like this, but she was able to pass the exam. So with that, let us start with today's first session. That is going to be Mega Revision Day 1. First thing what we have to see is this quote. Okay, nobody can go back and start a new beginning, but anyone can start today and make a new ending. So please understand that, and let us start with today's session. The first thing we would like to talk about is BLS. Can someone tell me what is the full form of BLS?
Basic life support.
Very good. Basic life support. Now, before I start with basic life support, there are two types in with respect to cardio. One is basic life support and other one is ACLS. What is the difference between basic life support and ACLS? This is an FMG question.
Presence of defibrillator, usage of defibrillator.
Okay, but little more. Can someone use exact answer? That's almost right. Anyone else? These are all PYQs and I want you guys to answer because I know all the answers. I want you guys to know the answer. Even if you answer wrong, it is completely okay. Like that, you will never forget the question again. So I'm asking one more time, what is the main difference between ACLS and BLS? Anyone?
BLS is like primary thing which we can do as a doctor, and ACLS provides more advanced gadgets or things which will be helping us.
Okay.
We use drugs in ACLS.
Very good.
In BLS, we don't use drugs.
Very good. That was the previous question. Okay, this they ask you the main difference between ACLS and BLS, the use of drugs. Okay, the use of drugs. Now, what type of drugs do you see in ACLS? 3 are there. Can anyone answer? Number 1,
epinephrine, adrenaline.
Okay, epinephrine, adrenaline, both are the same things. Very good. So number 1, epinephrine. If
Atropine.
epinephrine, very good. Amiodarone.
Atropine.
And
Atropine.
no, not atropine. Atropine is the drug of choice for bradycardia.
Lignocaine.
And last,
Very
lignocaine.
good. Very good, Doctor. Very good, Doctor. Lignocaine. Okay, lignocaine, lidocaine, both are the same names. Okay, so make sure you answer this very nicely. This is a previous year question. The main difference between ACLS and BLS is that the use of drugs is there in advanced cardiac life support. What are the drugs? Epinephrine, if you talk about amiodarone, and lignocaine. Now, let us start with basic life support. Now, just imagine, doctors, that you're right now in the Delhi airport, and right now you're just going to board the flight. Maybe 60-year-old gentleman just beside you, he fell unconscious. The first thing what we have to do is, you remember this mnemonic is SRS. Number one thing what you're going to do is, you're going to check the scene safety. Now, what do I mean by scene safety? Scene safety means is, for example, if this person has fallen near maybe an electric wire, or maybe he has fallen around an escalator, or maybe the ground is not flat enough. These conditions are not favorable for a CPR. So that is why make sure that you are in a safe region. If it is in the hospital, obviously it is a scene. The scene is safe already. But in case of anywhere out of the hospital, these are very important things which you need to know. Okay. Now the next thing is R. R stands for responsiveness. Now, how are you going to check the responsiveness? You're going to tap the shoulder. You're going to ask, Bhaiya, Utto, okay, if it's the male or female, anyone, just try to wake them up by tapping the shoulder. Just say, oh, like, who are you? What are you okay? Or something like this. You're going to ask the responsiveness. Okay. And the next S is standing for scream. Okay. So remember this order. This order has been asked in like INI. What is the first step? SRS.
ఇప్పటిదాకా సౌండ్ క్లారిటీనే ఉందా?
Can whoever is just, can you turn off your mic, please? Okay. And so the first thing which you have to know is scene safety. Okay. So scene safety, which will be the risk, number one is S, second is R, and the other third is S. So remember, scene safety, responsiveness, and the third one is going to be scream. Now after this, which you will see, is going to be your fourth one. This is actually seen in the US, and in US it is known as activated emergency response. It is known as activated emergency response, and there where you call 911. So first four steps are clear. The fifth step is that you have to procure the AED. Now, can someone tell me what is the full form of AED? Doctors?
Automated external defibrillator.
Very good. It is an automated external defibrillator. Okay, automated external defibrillator. A very important PYQ question. So first 5 steps are done. The sixth step which is there is going to be checking the pulse. Now check the pulse and breathing. Both, this is another PYQ question. Both of them should be done within 10 seconds. Both of them should be done within 10 seconds. A very important thing you should need to know. Okay. Now how are you going to check the pulse? First of all, what you're going to check the pulse is going to be in the carotid area over here. Now, what is this area, this bony prominence? You can try and touch yourself. There is some bony kind of prominence. This is known as a tubercle. This tubercle is known as Cisnat tubercle, anatomy question, also known as the carotid tubercle. Okay. If you'll ask me exactly what is this, the exact thing is, it is felt against the transverse process of which cervical vertebra? It is by the C6 vertebra. It is by the C6 vertebra. Just difference between BCLS and ACLS is the use of drugs. The 3 drugs which you use in ACLS are epinephrine, amiodarone, and lignocaine. So whenever you talk about the first safety in case of your basic life support, the first thing is you have to check scene safety. After scene safety, you will check for responsiveness. Are you okay? Are you okay? The third step is you have to scream. Ask everyone to help, because right now there is a situation where you need help. Alone you cannot do this. You can't do this thing alone. The fourth step is activate emergency response program. Activate emergency response program. The fifth thing is you'll ask someone to go and get the AED. The AED full form is automated external defibrillator. Whatever we are going to discuss in this sessions, these are all PYQs. There is not even one thing which is like not necessary. Everything is very important. So if you have any doubt, text me or just like unmute yourself and please tell me, please repeat. We will repeat it. Okay. There is no question which is silly. Everything is a valid question. The sixth step, which is very important, is to check pulse. Now, Dr. Saab, you need to know that whenever you check the pulse and whenever you're checking the breathing, both of these two things should be done within 10 seconds. This is a question. It should be done within 10 seconds, not more than 10 seconds, within 10 seconds. How are you going to check the pulse? You are going to check the pulse by palpating around the carotid area. This area, this bony prominence which is there, this is a tubercle which is known as carotid tubercle or Cisnat tubercle. It is the transverse process of which cervical vertebra? It is C6. Very important is it is C6 vertebra. Okay, till here we are discussed. Let us move on. So after this, if in 10 seconds you notice that there was no pulse, how are you going to check the breathing? The chest movements or through the breath of the nose or like mouth, right? If you notice that there is no no cardiac involvement, no respiratory involvement, you have to start CPR, cardiopulmonary resuscitation. Now, whenever you start with CPR, this is your AED. Automated external defibrillator, you need to know how the pads are placed. The right pad is placed, the right pad is placed just below the clavicle, so it is known as infraclavicular region. The left pad is placed below the nipple, moving towards the axilla. I'll repeat again. The right pad is placed just below the clavicle, and the left pad is placed below the nipple, moving towards the axilla. Okay? Now, if they will ask you what is chest compression, can someone tell me what is the ratio of chest compression in an adult?
30:2.
Very
30
good.
is to
Very good, doctor. Very good. Now, what is the meaning of 30:2? 30 means after 30 chest compressions, then I'm going to give 2 rescue breaths. Now, 2 rescue breaths should be done. The rescue breath duration will be how much? Around 6 seconds, right? 6 seconds. And in 1 minute, how many rescue breaths should be done? At least 10 to 12 rescue breaths. This is also very important clinically as well. Okay?
Sir, sorry to interrupt.
Yes.
Will you be sending the annotated notes too?
Yes. All before, after, we will, for this 4 days, we're going to put unannotated, then annotated, because some of
Okay.
the doctors requested me to put some. They wanted to print the notes. That's why I put it before. Don't worry. Okay.
Okay, thank you, Doctor.
All right. So one CPR cycle. If someone will ask you how long is one CPR cycle, what will be your answer? How many minutes?
2 minutes.
Very good. It is 2 minutes. These are all PYQs. If no one is able to recall, it's okay. Now you recall. Answer it wrong, no problem. At least now you will answer. Then so that in the exam, if this question comes, you will be able to remember that this was the answer. Okay. Next, DC shock. Now there is DC shock. Now I'll tell you in which conditions do you apply DC shock and other conditions where you cannot. But before which we'll just continue with the CPR. Sternal decompressions, sternal depressions. In adult is going to be 5 centimeters. In children, it is going to be 2 centimeters. 5 centimeters is equal to 2 inches. This is also a PYQ. Now, after your CPR, you're doing it. Eventually, there will be a time where you will see when you put the AED machine is going to check. It is going to analyze the ECG, whether this arrhythmia is shockable or whether this arrhythmia is non-shockable rhythm. How do you differentiate which are the shockable rhythms and non-shockable rhythms? Shockable rhythm examples are ventricle fibrillation. Rhythm which will be there. There are 2 types of shockable rhythm. The number one is ventricular fibrillation, and the other shockable rhythm is pulseless ventricular tachycardia. Okay, pulseless ventricular tachycardia. These are the 2 conditions which you can rhythm. And who is this person? There is one person who's keeping on speaking. Okay. Then this is a shockable rhythm. Now, which are the non-shockable rhythms? The non-shockable rhythm you should know is asystole, okay, which means cardiac arrest. And the second one is PEA. Can someone tell me the full form of PEA?
Pulseless electrical activity.
Very good. Okay, so the answer is pulseless electrical activity. Okay. So now, why is this shockable rhythm and non-shockable rhythm? The reason is a DC shock is the DC shock ka purpose is not to restart the heart. Okay, very important question is that what is the use of DC shock? It is not to restart the heart, but it is to change the arrhythmia. It is to the arrhythmia which is causing it is trying to change it up. So that is why in asystole condition where there is no there is no electrical movement, there is no use of DC shock. For these conditions, DC shock is contraindicated, and you have to just give epinephrine. Only give epinephrine. You can remember this case by the Indira Gandhi when she was shot in Delhi. She had around 20 plus shots. She was suffering from asystole because of pulseless electrical activity. You can remember a condition of pulseless electrical activity by if someone is heavily bleeding because of hypovolemia. The heart is trying to pump, but because of there is hole maybe in the aorta or somewhere, the blood is not able to flow throughout the body. So that is such conditions where you need to know that is pulseless electrical activity. Now, if they will ask you, doctors, now you have to answer the most common organ damaged in CPR. What would be your answer?
Sternum.
Organ. The most common organ.
Liver.
Hanji?
Liver.
Okay. See, if they'll ask you the most common solid organ, your answer will be liver.
Lung.
Okay.
Okay.
Very good, doctor. The most common organ overall damage is your lungs. Okay, please make sure that these questions will not be a mistake. If they ask you solid organ, lungs is not a solid organ, so your answer is going to be a liver. That also because of the Xiphi sternum, sometimes it can break. Now, second thing is the most common overall is going to be your lungs. If they will ask you what is the fulcrum in CPR, the fulcrum which will be which joint? Can anyone answer which joint?
Pelvic.
The pelvic joint is? It is the hip joint. Okay, it is the hip joint. Did everyone understand this so far?
Yes.
Everything good? All good?
Yes, everything good.
Okay. So I hope CPR is done. If anyone has a doubt, no problem. You can ask me. We can unmute and please answer. We'll describe the whole thing again. There is no issue. The second thing which I will start discussing is, because since we are less in time, I'll move on. First, we're going to talk about head trauma. Now, in head trauma, a first classic case we'll talk about is you have an like 20-year-old male who was playing cricket. So someone told him to wear a ball, helmet, because there was a fast bowler, but he was like, it's okay, I'll manage. The guy bowled a bouncer. After the bouncer, it directly hit his head. The player fell unconscious. Then he woke up again. Then he went conscious. Then he woke up again. This thing, which is unconscious conscious, what is this known as, doctor?
Lucid interval.
Very good. This is known as lucid interval. Now, one thing you need to know that can you tell me, is lucid interval specific character of EDH?
It is seen in both ADS and SD.
Very good, Doc Saab. Remember, this has been asked as a question. Lucid interval is not a characteristic feature of EDH. EDH is diagnosis of epidural hemorrhage. We'll talk about it later. But remember, lucid interval can happen in other conditions like SDH as well. So this thing, lucid interval, is commonly seen in EDH, but it is not a characteristic feature. Please note this well. Okay, so what happens is this patient now, his friends are very worried. What is happening to him? They took him to the hospital. So as the players described the doctor, what happened is, so the doctor is like, okay, most probably there's a head trauma. We are going to do a scan. Now, one thing, doctor, what you have to remember is, whenever you have any head trauma which is related to bleeding, you have to do a CT scan. Okay. And now, what type of CT scan are you going to do? Are you going to do a contrast one, or are you going to do a non-contrast CT scan?
Non-contrast.
Very good, doctor. See, like, I'll tell you one thing. Look, everyone, there are few people who are answering right now. I want everyone to answer. Reason being is, if you guys speak out, there is, I know some people are introverts. They tend to speak less. But if you speak out now, the chances of you to remember this and remember this for a longer time will be increased. If you just silently know, I know most of you guys know the answer. But if you try to speak out, it will be retained for a longer time. Okay. So what CT scan are you going to use? NCCT or CT scan? NCCT. Just non-contrast enhanced CT scan. Whenever you're having any trauma related to bleeding, you will not put any contrast. You will just do an NCCT scan. Either it is EDH, either it is SDH, SAH, or any condition, it is going to be NCCT scan. Now, in the NCCT scan, what you're going to find is, you're going to find this idli shape. You can say this as a idli shape. You can say this as a lenticular shape, or you can also say this as a biconvex shape. This classic picture, whenever you have a biconvex type lesion in the NCCT, gives you the diagnosis of EDH. What is the full form of EDH, doctor?
Epidural hemorrhage.
Extradural.
Very good. Everyone, very good. Now, see, now people are getting comfortable. That's good. Okay, so the answer is EDH, that is epidural hemorrhage. Now, epidural hemorrhage, what is the issue? Why this is such a dangerous condition? The issue is that this mass effect is so much that it will start applying pressure to the ventricles. Eventually, when it applies pressure to the ventricles, it is going to go and involve in the brainstem. Let us start now anatomy. Can someone tell me what are the parts of the brainstem? This is also a PYQ. Brainstem. See, we are not going to talk about subject by subject. In the exam, there is not going to be, okay, this is going to be an anatomy question, this is going to be physio question. Everything is going to be integrated. So we are going to do in this 4 days also integrated. Please tell me what are the parts of the brainstem.
Midbrain, pons, and medulla.
Very good. Midbrain.
Pons and medulla oblongata.
Very good. Pons and medulla. Very good. Very good, doctor. See, no, midbrain, pons, and medulla. So then, good, we asked about this question. Now, doctor, don't do this question wrong again. Cerebellum is not the part of the brainstem. Midbrain, pons, and medulla. Now, the issue is that in the midbrain, you have the respiratory center, you have the circadian rhythm and all. Because of this pressure which is coming in this epidural hemorrhage, they are going to cause problems over here. Because of problems, patient is going to go in coma. Now, another question with respect to forensic medicine. How do you say, what is the definition of a brain dead patient? Can someone tell me how much GCS?
Less
Three.
than 8.
Less than
Less
3.
than 3.
No, 3. It's
No, no,
3.
3.
Yes, there is
Less
no
than
such
8.
value of less than 3. It is only 3. Okay, brain dead patient is defined as, if you see, Glossman Comer scale is 3, not less than 3. Okay, so now this is such a dangerous condition. Now, in this condition, what you have to do is, first of all, let us write about the arteries which are getting involved. Diagnosis, very good, Dr. Saab, you got it right. Now, the next question is, what is the artery involved in epidural hemorrhage? Can someone tell me, please?
Middle
Middle
meningeal. Middle
Very good,
meningeal.
Dr. Saab, very good, Dr. Saab. Middle meningeal artery. Now, Dr. Saab, I want to tell you something. This is not only the answer. This was the correct answer 4 years ago. Now they will ask you, middle meningeal artery is the branch of further which artery?
Maxillary.
Sorry?
Maxillary.
Very good, Doctor. Very good, very good. It is a branch of maxillary artery. This is a PYQ which they ask this time in NEET PG. Maxillary artery. Next, what is maxillary artery a further branch of?
External carotid.
Very good. Very good. You guys are already answering this. You know, this was a tough question last time in this revision class. They were not able to answer. So the chances of you guys are very already, you know, well versed. That's very good. External carotid artery. So please understand one thing. External carotid artery is the big artery. Its further branch is the maxillary artery. And after maxillary artery, the further branch is middle meningeal artery. Okay, so these are the ones which are usually damaged in epidural hemorrhage. Now, as I told you, the investigation of choice is going to be NCCT scan. Whenever there is any, maybe it is hemorrhagic stroke, either SDH or EDH, the answer is going to be NCCT scan. Now, EDH with posturing. Now, in posturing, there are two types of posturing which is very important. Again, let us talk about forensic. You have one thing which is known as decorticate. And what is the other thing, Doctor? Other one is
Decelerate.
Deliberate.
decerebrate. Very good. Now, can someone tell me the difference between decorticate and decerebrate?
Decorticate is flexion and decerebrate is extension.
Good. Very good. Now, this thing is usually confusing at the time of exam. So, how will you remember? It is very easy. You see, in decerebrate, there are so many E's. Right, doctor? There are so many E's in decerebrate. So, the patient will be in the extension. Okay? While in decorticate, the opposite. Just remember one thing, so then you don't have to remember the other. It is going to be flexion. Now, the another question they will ask you is, which is more dangerous, decorticate or decerebrate? Answer anything. See, doctor, if you don't know the answer, it is okay. Just answer. Decerebrate. That's the correct answer. Why? Because look, the order of brainstem is also very important. As we told you, the brainstem is midbrain, then the pons, then the medulla. So, whenever the damage is going from up, to down, that time you can see that the condition is worsening. So, pehle the patient is going to be decorticate, then the patient is going to be decerebrate. Okay, and these are dangerous signs. These are not good signs. If your patient is going to, this 20-year-old is now going to go decorticate, then decerebrate, this gives an emergency condition. You have to go with burr hole surgery. Very important. Now, if they'll ask you what is overall the treatment of choice, so this is very important. Please read the question very properly. Whenever you're going to give the upcoming FMG exam, I want you guys to remember, see, most of you guys are understood the topic well. So you guys know the place where you're going to make the mistake is by seeing these four things. Always watch none of the above, all of the above, except, and like for this question, what is the next best step and what is the management of choice? If I will tell you a patient, EDH patient is decorticating, decerebrating, what is your next management? What is your answer, Doctor?
Burr hole
Burr hole.
surgery.
If I will tell you that the patient has EDH, what is the treatment of choice? What is your answer?
Decompressing
Hemicranial.
So now you guys understood what I'm trying to say. Please make sure that you guys don't do this mistake. Okay. So in EDH, the treatment of choice is going to be decompressive hemicraniotomy. Is everyone clear with EDH? No doubts with EDH? Can I proceed?
Yes.
Okay. So the next topic we'll talk about is a 70-year-old patient who's a type 2 diabetic. Okay, and he slipped in the bathroom. His head hit, but then he had a minor bruise, but he did not get unconscious. There was no such lucid interval. After a while, you notice that the next day the patient had headache and vomiting. Can you tell me why this patient is suffering from headache and vomiting? Because of try think logically. Because see, in the exam also you just have to apply logic.
Transcranial pressure.
Very good, because the pressure inside the head is increasing. That is
Cranial,
why
yeah.
headache and vomiting is happening. After 7 days, patient had focal arm weakness. Now the son and the daughter, they were kind of worried what happened. They took the patient to the hospital. When the doctor took the history, he found out that this guy fell 1 week ago. Then again, they thought that there can be trauma to the head. Again, the investigation of choice was NCCT. Now, when they did this NCCT, what they found out is they found a semi-lunar type crest. In EDH, it was either biconvex or idli shape or lenticular. This shape is crescentic. This shape is also known as concavo-convex. Whenever in the CT you're having a concavo-convex type section, what is your diagnosis, doctors?
Subdural hemorrhage.
Very good, doctor. It is subdural hemorrhage. Now, subdural hemorrhage is of 3 types. It can be acute, subacute, or chronic. Now, the difference between acute and chronic is in your CT scan, if it is an acute episode, it will be bright white in color. But if it is going to be chronic condition, it is going to be dull or black in color. So you can see over here, just with the image example, if this was acute, you could see, just imagine this was the bright white color over here. Okay, then it was subacute, you had seen some hypodensities, and eventually in a chronic I didn't mark over here, in a chronic SDH it will be completely dull in color. I'll show you the image later. What you have to remember with respect to SDH cases is you will have such history, maybe a stuntman, maybe a boxer, Alzheimer's, Parkinson's, or diabetic neuropathy. These people are much prone to get SDH because they do not remember that they had a fall or not. Now, what will be your treatment? First of all, tell me which is more dangerous, doctor. Is SDH more dangerous or EDH more dangerous?
EDH.
EDH is more dangerous.
EDH.
That is why, very good, doctor. That
Midline
is why
shift.
we did exactly. There was a midline shift. That's why we had to do one whole surgery. Over here, SDH is not such a serious thing. That is why the patient had 1 week. EDH, within 24 hours, the person can die if you don't do the treatment. So, what is the treatment with respect to subdural hemorrhage? First, we are going to do is osmotherapy. In osmotherapy, you can use drugs like mannitol, acetazolamide, and glycerol. One thing which you cannot give, and it is contraindicated, is hypotonic solutions. Because if you give an hypotonic solution like 0.45% NaCl, it was going to worsen the cerebral edema. So remember, contraindication is hyposaline or hypotonic solution. Now, the question over here comes is, what is the source? In EDH, it was middle meningeal artery. Over here, doctor, tell me what is the source in case of
Barry
subdural?
aneurysm.
Branching veins.
Very good. It is venous. It is cortical bridging veins. Very good. It is cortical bridging veins. Okay. This is the main thing which they're going to ask in SDH. Now, next question. A 25-year-old female, whenever you have a classic history, doctor, whenever they say worst headache of my life, thunderclap headache, what is the first thing which should come in your mind?
Subarachnoid.
Very good.
Subarachnoid.
Subarachnoid hemorrhage. Very good. Subarachnoid hemorrhage is the answer. Now, in subarachnoid hemorrhage, again the investigation choice is going to be NCCT. Where is the bleeding in subarachnoid hemorrhage? The bleeding in subarachnoid hemorrhage are either in the intersphincter you can get the anterior cerebral artery as bleeding,
Barry aneurysm.
or in the Sylvian fissure you can get MCA, which is known as middle cerebral artery. Now, doctor, what is this classic sign which is seen in subarachnoidal hemorrhage?
Star of death.
Very good, doctor. This is a previous year FMGE question only. This is known as star of death. Okay, this is known as star of death pattern, which is seen in subarachnoid hemorrhage. Please do not forget this. You can see this white part over here. See, the very easy way to know whether it is an MRI or a CT scan is that this is a CT scan. How I know? The bones over here are white in color. Okay, in MRI, the bones are going to be dull. So that is a very distinguishing feature. Okay. Now, over here, I can see the star-like pattern. This is known as the star of death pattern seen in subarachnoid hemorrhage. Along with that, you can see this fissure bleeding is there. This is the middle cerebral artery involvement. Okay. If I'll ask you, what is the most common cause of subarachnoid hemorrhage? What is the most common cause?
Barry
Aneurysm.
aneurysm.
No, Barry aneurysm is not the most common. That is the second most common. The most common cause of subarachnoid hemorrhage is trauma.
Trauma.
Okay, very important. The most common you see cause of subarachnoid hemorrhage is trauma. If I will ask you, what is the drug of choice? This is FMG 2022 question. The drug of choice for subarachnoid hemorrhage is
Nicotine.
very good, doctor. Very good. Nimodipine. Very good. Okay, nimodipine is the drug of choice for subarachnoid hemorrhage. Okay. Now, someone was talking about berry aneurysm. Let us talk about berry aneurysm. Berry aneurysm, where does it commonly occur? First of all, what is the meaning of aneurysm? Aneurysm is nothing but a outpouching. If there is a blood vessel, or here it comes outpouch, that is the outpouching. Now, where it is commonly seen, another PYQ, it is seen at the junction of the anterior cerebral artery and the anterior communicating artery. Make sure that you know this very well. Okay. The next thing is, where do you see the lesions in berry aneurysm? The lesions is in tunica dash degeneration. Can someone tell me tunica which part?
Media.
Tunica.
Media.
Very good, doctor. Tunica media. See, anyone is answering wrong. Very good. Now you guys will never do this mistake. Okay, don't care if someone is going to be, oh, this person is saying wrong, this person is saying right. Are hell with people. You paid, this is your seat. No one is going to give your examination, it's going to be you. So even if you say if 10 questions I'm going to ask 10 wrong, no problem. Inside it should be correct. Okay. Now, investigation of choice for Benny aneurysm. Now, you know that Benny aneurysm is a blood vessel involvement. So, obviously, there should be angio, that is blood vessel. Either you can do CT scan or MRI. Now, based on expense, CT is cheaper, so people prefer CT. Okay. Now, the treatment of choice for Benny aneurysm is endovascular coiling. Basically, this aneurysm is there. They're going to put a coil and they're going to flatten out the blood vessel. These are all the important anatomy questions for Benny aneurysm. Remember, what is the most common cause of subarachnoid hemorrhage? Doctors? Trauma. What is the drug of choice? Now we're going to ask, let's revise quickly, okay? What is the drug of choice for subarachnoid hemorrhage?
Hemorrhapine.
Good. Epidural hemorrhage is, like in epidural hemorrhage, is lucid interval a characteristic feature or not a characteristic feature?
Not a character. Not a character.
What is shockable rhythm? Can someone tell me what is shockable rhythms? What are two shockable
EVT
rhythms?
and VT.
VTech and
PVT.
Very good,
yeah,
doctor.
PVT.
Very good, doctor.
So your voice is getting laggy.
1 second, doctor. 1 second. Just give me a second. Hanji. 1 minute, 1 minute, 1 minute. 1 minute. Doctors, actually, there are a few more, around 20-30 people who want to join. So then that's why we're just trying to make a Google Meet, like Google Duo, which like one docs up tool, right? So if that is confirmed, then I'll send you the link and we'll continue there. But till then, let us continue. Is it okay, everyone? Can we proceed?
Yes.
Okay. So then we were revising, as we said, okay, what are the 3 drugs which are seen in ACLS? Can someone please tell me?
Epinephrine.
Amiodarone, epinephrine, levodopa.
Very good. Very good, doctor. Very good. So at least now so far we have done with the basic things which are very important. Now, next question, doctor. A 40-year-old hypertensive patient, okay, a hypertensive patient in a sales meet, he had sudden facial lag. Okay, facial lag. Suddenly his hands started getting numb. He was not able to speak something, and his tongue also was like his lips also was going down. The first thing what comes in mind is, doctor?
Stroke.
Very good. The first thing which comes in mind is stroke. Now, when you talk about the examination of stroke, there is an examination where you will see if this is my sole, okay, of my foot. I'm going to take a sharp object and I'm going to do like this. What is this test? What I'm trying to test?
Rudzinski.
Now, very important thing in Babinski is nowadays they're asking the image, what is normal or what is abnormal? If the foot clenches like this, that is called as normal Babinski response. That is not a Babinski positive. It is normal. The patient has no issues. If instead of clenching, it goes up, okay, it goes up, that means there is corticospinal tract involvement. There is some problem, okay. Babinski, this is an anatomy question as well. If there is Babinski positive, which means which track is getting involved, doctors?
Corticospinal.
Spinal tract. Okay, corticospinal tract is getting involved. Okay. So when you were doing the workup for stroke, you found out there was facial lag. Patient was not able to speak properly. The hand was getting numb. Okay, Babinski was positive, and projectile vomiting. Another PYQ. What is projectile vomiting, doctor?
Sudden vomiting.
Sudden vomiting. Okay, so can you elaborate what is sudden vomiting, doctor?
Which comes without nausea.
Very good. Very good. This is the previous question. Very good. When there is vomit, okay,
Without nausea.
without nausea. Vomit without nausea. Okay, vomit without nausea is known as projectile vomiting. Now you know that it is a type of stroke. We have an idea that it is a type of stroke. But stroke also has multiple types. Either it is because of lack of oxygen or lack of blood supply, which is known as ischemic stroke. Second type of stroke is when there is too much blood, that is hemorrhagic stroke. To distinguish between hemorrhagic stroke and ischemic stroke, again, we have to do an NCCT scan. So just keep this in your mind. Whenever you have any issue associated with trauma, you will do an NCCT scan. Okay. In the exam, both A and B option will be there. NCCT and CT. Make sure that you're going to mark NCCT scan. Now, if this is a situation of stroke, what you're going to do is you have to order the CT scan within how many minutes? Does anyone know? Within how many minutes you have to order?
5 or
Within 40 minutes?
25?
Very good, doctor. Very
30
good.
minutes.
25 minutes. This is a PYQ. Within 25 minutes, you have to tell the technician, order them. Within 25 minutes, you have to get the, you have to do the report. Now, to analyze this report, how much more time do you need? Go to imaging. How much time?
45 minutes.
Very good, doctor. 45 minutes. Okay, this is also a very important question. Within 45 minutes, you have to analyze, which means I'm going to order within 25 minutes. Suppose now one patient came at 5 p.m. Within 5:25 p.m. we have to do the test, and by 5:45 I have to interpret the diagnosis. Okay. If I have found out the diagnosis as hemorrhagic stroke, which is intracerebral hemorrhage, tell me, doctor, what is the most common site for intracerebral hemorrhage? What is the most common site?
Putamen.
Very good, doctor. Very good. It is putamen. Okay, putamen is the most common site. Now, in putamen further, if you see why is this patient suffering from facial lag, dysarthria, is because if there is further involvement of the posterior limb of the internal capsule, that is the responsibility why the patient is losing all the tract. And around this internal capsule, you have this corticospinal tract. That is why Babinski is coming positive. Okay. Now, if they'll ask you what is the blood vessels which are involved in intracerebral hemorrhage, your answer should be it is the penetrating branches. Make sure you're answering this penetrating very well. Penetrating branches of the lenticulostriate artery. Penetrating branches of the lenticulostriate artery. Now, can someone tell me what is the difference between hypertensive crisis, hypertensive urgency, and hypertensive emergency? This is a PYQ as well.
Hypertension
It's difference of blood pressure.
Blood pressure, okay, not exactly. Anyone else?
BP plus organ, target organ damage. Bleeding of.
Okay, so many people have ideas. Let us solve it quickly. Okay. See, hypertensive crisis is a broad term. Okay. Hypertensive crisis is further divided into hypertensive emergency and hypertensive urgency. The definition of hypertensive crisis is whenever the systolic blood pressure is more than 180 and the diastolic blood pressure will be more than 120. Now you know that this is a hypertensive crisis. Now this will be further divided into two. If there is end organ damage, it is known as hypertensive emergency. If there is no end organ damage, it is known as hypertensive urgency. Is everyone clear?
Yep.
Okay. Now tell me one thing, how will you remember? This is a very easy way. Which is a bigger word? Emergency is a bigger word, right? So remember, more bigger, more trouble. So end organ damage will be in hypertensive urgency. In hypertensive emergency. Okay. Now, if we will be talking about which I talked about, putamen, let us talk about a little bit about anatomy. This is the structure which you have to remember. They will usually ask you to identify. So first you will have the ventricles. Quickly, let us talk about the ventricles also over here. What is the first ventricle you talk about? There are two lateral ventricles, right? You reach the lateral ventricle for the third ventricle. What is this foramen called as?
Monroe.
This is known as foramen of Monroe. Very good. From the third ventricle, you reach to the fourth ventricle, correct? Now, from the fourth ventricle, it further divides into three parts. This third ventricle, from third ventricle to fourth ventricle, this is known as aqueduct. What is this aqueduct called as? Aqueduct of Sylvius. A pediatric question is the most common cause of hydrocephalus is obstruction to the aqueduct of Sylvius. Okay. Now, from the fourth ventricle to the subarachnoid hemorrhage, to the subarachnoid space, there are three foramens. Okay. Which are the foramens?
Jendi and Lashka.
Very good. Foramen Magendie and foramen Lashka on the lateral side. So how do I remember it? Very easy. Foramen Magendie, M for midline, M for in the middle. Foramen Lashka, L for Lashka, L for lateral side. So like this, you will not forget. They will ask you in identification which are the two sides. The two sides are Lashka. Overall, let's quickly say one more time. You're having the lateral ventricles. From the lateral ventricles, from a foramen, you reach the third ventricle. What is that foramen called? Foramen of Monro. From third ventricle, you go to one duct. That duct is known as aqueduct of Selvius. From the aqueduct of Selvius, you reach the fourth ventricle. From fourth ventricle, you have three foramens. The midline, so foramen megendi, and along the two laterals, so foramen Lashka. Now, whenever you talk about this structure, a very important anatomy question also that they'll ask you to identify. See, over here is the lateral ventricles. Just aside the lateral ventricles, this area, this is the caudate nucleus. This is the caudate nucleus. Okay, just below the caudate nucleus and lateral to the third ventricle is your thalamus. Okay, it is your thalamus. Now, how do I remember what is up, what is below? Simple. In the alphabetical order, C comes before T. So remember, C will be top and T, thalamus, will be bottom. Clear? Next thing what you have to remember is this area which we talked about, putamen. See, Toxam, putamen and globus pallidus together, they make a nucleus. Can anyone tell me what is the nucleus called as? Combination of putamen and globus pallidus.
Lentiform nucleus.
Very good, very good. Lentiform nucleus. These are all anatomy questions. Okay, make sure you know this by heart. Okay, this is going to be lentiform nucleus. So the combination of putamen and globus pallidus is going to be there. Okay, doctor. So we'll do one thing. We'll finish till this topic, epidural, subdural, and subarachnoid, and then we'll go on to the Google Meet where you can join more. So I'll continue till then. Okay. Now, so as I talked about you, let's go just a quick summary. Lateral side to the ventricles, what will be there? Caudate or thalamus?
Caudate.
Very good.
Caudate.
And just lateral to the midbrain, what will be there?
Thalamus.
Lentiform nucleus is forming by two structures. What are the two structures called?
Putamen and globus pallidus.
Very good, doctor. What is the most common area involved in case of intracranial hemorrhage?
Putamen.
Very good. What is the drug of choice for subarachnoid hemorrhage? Nimodipine. Very good, doctor. Very good. Now see, over here for just an explanation, like whatever we talked, it is right only over here. This just on the top will be your caudate nucleus. You can see over here, just on the top is caudate nucleus. Then below this area is your thalamus, and then you'll have the internal capsule and the putamen. Now, if I will talk about this structure, if any time a question comes like this and identify what is the condition, you can see a bleeding over here. Because of the bleeding, there is a midline shift also, and they are asking you history of hypertensive patient, sudden stroke. You see this. What is your diagnosis? Ischemic or hemorrhagic stroke?
Hemorrhagic.
Hemorrhagic stroke. Very good, doctor. Very good. Now see, the issue with hemorrhagic stroke is you can't do too much about it. The patient mostly out of 45 minutes is about to die. So what the basic management you can do is to reduce the intracranial pressure. Again, give mannitol, acetazolamide, or glycerol. Now, we're done with the head traumas. These are the most important in surgery. We just now covered a surgery topic. So make sure you know. If I'll ask you this patient, okay, what is your diagnosis just by seeing? Number one, is it this CT or MRI? Number one, what number one question?
Bone black MRI.
MRI.
No, it is a CT scan.
It's a CT, calcified. Yeah.
This is all bone, Baba. This is all bone.
Yeah, bone. It's a CT.
Okay, so what is this diagnosis? The first one.
Subdural hemorrhage.
Be confident. One girl just now answered. You answered it right. I just want you to be confident. What was your answer?
It's SH.
Subarachnoid hemorrhage.
Subarachnoid.
No, it is not subarachnoid hemorrhage. See this classic picture.
Subdural hemorrhage.
Precentric. What is this?
Subdural hemorrhage.
Subdural hemorrhage. Yeah.
See, most of you guys had it in your first, mind ki haan, mere ko ye lag raha hai. This is what I thought. But when I started asking you again and again, you're like, no, why is he asking again? It doesn't matter how many times I'm going to ask you. You should be confident with your answer. Okay. Next question. Diagnosis, quick.
Epidural.
Why does the epidural hemorrhage? Because you can see this
Lentiform.
Doctor, in NEET PG, you know what they asked? People diagnosed this well, okay? But with EDH, you can see over here, there is air. And this air is known as pneumo, right? So they added pneumo plus EDH. So please make sure you see the answer the image very nicely. Don't be in a rush to answer and move on, okay? Next, what is this diagnosis, guys?
Subarachnoid hemorrhage.
Why subarachnoid hemorrhage? What is this?
Star of death.
Star of death.
Very good. What is the drug of choice for subarachnoid hemorrhage? Fast.
Nimodipine.
Doctor, very good. Okay, so now even though for people who do not understand the whole explanation, I have given everything in one line. In EDH, the classic history will be maybe trauma while playing cricket or maybe road traffic accident. What is the shape? Biconvex. What are the vessels involved in EDH, doctor? Please tell.
Middle meningeal artery.
Middle
Middle
meningeal
meningeal
artery.
artery,
If
maxillary,
middle meningeal artery is not there, maxillary artery.
maxillary,
If maxillary artery is not there,
External
External carotid.
artery. Very good, everyone. Very good. Subdural hemorrhage. History maybe a boxer, maybe a stunt man, maybe an old patient. Okay. What is the shape? Concave or convex or a lunar shape. Correct. And what is the blood vessel involved, doctor?
Bridging cortical veins.
Okay. Now see, everyone remembers bridging cortical. In the exam, how the trick was bridging cortical artery or vein. So what it is? Bridging cortical?
veins,
Bridging cortical veins. Okay. Subarachnoid hemorrhage. Classic two answers will come. Worst headache of my life or thunderclap headache. Very good. What is the blood vessel involved, doctor?
Middle cerebral artery.
middle
Cerebral artery.
cerebral artery, middle,
Okay. If they'll ask you which is involved in the Sylvian fissure, what is the artery?
Middle cerebral artery.
Very good. In this Sylvian fissure is going to be middle. And again, logic interhemispheric, which will be there? It is anterior cerebral artery. Okay. Now see, in intracranial hemorrhage, obviously it is penetrating branch of the lenticular artery. The most common location is the putamen. Putamen and globus pallidus together combine and form what?
Lentiform nucleus.
Okay. So I will just talk about this one last topic and then we'll just join in Google Duo. Okay. So then other people can join as well. Now, types of headaches. Very important topic is types of headache. Number one is whenever you are using your screen too much or maybe you're having too much stress, you'll have a band-like headache. The band-like headache is known as
tension headache.
very good tension headache. Second condition, there is a female, okay, a female who's having unilateral headache, okay. It is unilateral and it does not resolve by most of the drugs. What is your diagnosis generally?
migraine.
Now in migraine, how do you define migraine? There is 5 features which is known as POUND. What is POUND? If someone can tell, please. P stands for
Pulsatile headache.
very good, doctor. One is pulsatile. O is onset. It is going to be from 4 to 72 hours. Simi, please start. Okay, 4 to 72 hours.
Unilateral.
Unilateral. Very good, doctor.
Nausea, vomiting.
Nausea.
Very good, doctor. Nausea. And D is
disability in character.
Very good. Disability in character. What is the meaning of disability in character? It basically means patient is not able to work properly, not able to sleep, not able to go to the office as well. Okay. If they'll ask you what is the drug of choice for migraine, what is your answer?
Triptans.
Propranolol.
If one answer, sumatriptan will be your answer. Okay. If they'll ask you which is the fastest acting triptan, rizatriptan is the fastest acting triptan. Okay. Rizatriptan. Okay. Now, prophylaxis. Remember in P for prophylaxis, P for propanol. Remember, doctor, how they're going to confuse you in the pharmacology is the prophylactic drug is not the treatment of choice. So last time what they asked in NEET PG was which of the following is the drug of choice. Sumatriptan was asked and propanol also there. Some of people mark propanol, but no, propanol is not the answer. P for propanol, P for prophylaxis. Okay, make sure you know this well. Next condition, doctor, is a male patient. Okay, mostly it is common in male who is having a retroorbital pain over here. This patient is having so much pain that he's usually coming with the complaint of putting a pen in the eye and he's saying he's feeling better. This pain usually happens in one time of the day, maybe in the evening. Maybe yesterday he had at 5 p.m. Again today it will have 5 p.m. What is your diagnosis? Retroorbital headache. Okay, which is a cluster headache. Now, what they're going to ask you guys is what is the first management of cluster headache? The first management is if the patient comes directly, you have to put oxygen. How much liter of oxygen you're going to put? 12 to 15 liters of high flow oxygen. 12 to 15 liters of high flow oxygen. If they're going to ask you what is the drug of choice, over here for cluster headache also the same answer is sumatriptan, drug of choice. But if they'll ask you now, the prophylaxis is different. What was the prophylaxis for migraine?
Propranolol.
Gabapentin. Here in cluster headache, the prophylaxis is Viramapil or lithium. This is the PYQ. Okay, this came in FMGE itself. So the prophylaxis for cluster headache is Viramapil or lithium. Okay. Everything okay? Everyone understood?
Yes, doctor.